Hello, friends, and welcome back to another episode of the Concussion Nerds podcast. And this is an episode that I'm sure we will be talking about more and again in different ways and potentially with different guests in the future, because it is a topic that comes up so much and there's so much interest around it. And it's this topic of vision after concussion. And as a physical therapist, this is one of the other areas for me that is it astounds me. I'm intrigued by it. I want to dig deeper. I want to understand it more. I always giggled when I took vision courses to say, I should just go back to school and be an optometrist too. Literally, if I had my way, I'd be a physical therapist, a chiropractor, an optometrist, a naturopath, and a psychologist, but I can't. So I get to surround myself with amazing colleagues who can help me go deeper and support my clients deeper in these different areas when it is necessary. So, first of all, you hear often that vision can't be affected after concussion, which is so false, it's not even funny. Or the other thing that we hear a lot in this space, maybe not as much now, but definitely in previous years, was a client will share that something with my eyes doesn't feel right. But then they go to an eye doctor or an optometrist, and the optometrist is like, your vision's 20/20, you're fine. What typically happens after concussion is not the issue of visual clarity, but more our functional vision and our visual processing. So what the heck am I meaning by this? So first of all, let's think of vision and what clients will typically have challenges with or struggle with if vision's an issue. There might be issues with reading or comprehension of reading, right? So they have difficulty with the task of reading itself, and then they try to remember or share or summarize what they've read, but they aren't comprehending what they're reading. They might be getting more symptoms when they're trying to engage in visual activities. So visual activities of reading, watching television, watching a sporting event, trying to do things on screens, right? So when they're engaged in those type of visual activities, their symptoms increase. Those symptoms might be headache. It might be dizziness. It might be pressure in the head, right? So all these things can show up more when vision is an issue. Those are some of the biggies. In really busy visual environments, symptoms will increase, right? So this isn't necessarily the task of I have clear vision that's the problem. The challenge becomes when we think of vision and when we assess vision, we're looking at the functional component of vision and the processing component of vision. It's different pieces and different elements, right? So in the physical therapy world, in acute concussion, there's a common outcome measure that's called the VOMS, vestibular ocular motor movement screen. And while the VOMS is supported by evidence and supported by research, and we know that if people share they have an increased symptom score of 2 points of the outcome measure, it's indicative of a concussion, right? The VOMS has also been shown in the research to show us that if there is ocular motor challenges or deficits in the VOMS, that it is predictive of a longer recovery. There's other research that shows us that if someone has visual dysfunction with saccades, this research study used the King-Divic test, which is a reading saccadic test, and it's timed for speed, and it gets difficult through these different progressions of the test. But that when they assessed people baseline after just sitting, and they got a certain score, and then they put them through an aerobic component or an exercise component to get their heart rate up, and then they retested the visual piece. If there was an exercise-induced visual dysfunction, right? So that's what they're calling that. They have a difference between the two measures after exercise. If there was an exercise-induced visual dysfunction, it put them at 3 times the risk of developing persistent concussion symptoms. That is huge. And that type of outcome measure is so easy to implement in our clinics that we're already starting to shift what we're doing at my clinic in Symphony in our acute assessment to include that component. 3 times the risk of developing persistent concussion symptoms if they had an exercise-induced visual dysfunction. That's pretty significant, right? So if you're a clinician listening to this, when we always talk about in that acute phase, we must be assessing the different phenotypes or the different clinical profiles. And vision is absolutely one of those because the studies are showing us over and over and over again that if there is a visual dysfunction after concussion, it increases the time frame of recovery. So when we're having that discussion with our clients of most people improve within the 4 weeks, right? But we now know that there's like more like 40% that take longer. But if visual dysfunction is present, we can already share with our client that we're probably looking at a longer recovery period. And that's okay. It doesn't mean we're not going to recover. It just means it's going to be a little bit longer. Okay? This is why when we do these things, we need to look at it. This is why we can't just assess one component. And you're going to hear me preach about this through this podcast all the time. But when we're looking at vision, what do we need to be looking at? So I mentioned the VALMS already, right? The VALMS is a validated, standardized outcome measure that's been used in research over and over again. If you've looked at the new concussion consensus from Amsterdam, there's a modified VALMS in the scope. So in the office assessment, there's a modified VALMS. It is a tool to assess vision. However, truly in the VALMS, the only thing that it asks you to measure is symptom provocation. So what does that mean? That means that if you have the client do a smooth pursuit, so being able to look at a target and follow it with their eyes, you measure their symptoms before you do that task, then you do the task in a standardized way, and you measure their symptoms after. That's it. That's what the VALMS ultimately measures as its outcome measure is symptom provocation. As a clinician, I'm going to argue that that's not enough, especially to provide individualized treatment. One of my biggest pet peeves, I think, as a clinician, and one of the biggest questions I started asking as a clinician several years ago was everything I was taught through some of the different courses that I had done was a bilateral activity. If you're going to do smooth pursuit, practice it left and right, practice it up and down. If you're going to do saccades, always go back and forth and up and down and do all the directions. If we're going to do range of motion in the neck, we're going to do the whole thing. If we're going to spin in chairs or do vestibular stuff, we're going to spin to the left and then we're going to spin to the right. Why are we doing everything to both sides of the body? Right? We need to learn how to interpret these tests at a more granular level so that we can make our treatment plans more specific. So when I say when we're looking at vision, we're looking at both a functional component of vision. So functional just means like, how are the eyeballs moving? How are they moving to objects, tracking objects to take your world in? And then how is our brain processing that information? So as a physical therapist listening to the episode, you need to be looking at multiple different things. Yes, we need to look at our smooth pursuits. We need to look at saccades. We need to look at convergence. And we need to look at accommodation. Now, not only do we need to look at those pieces, but we also need to look at the components of those pieces. What does it look like left to right? What does it look like up to down? What does the speed look like different side to side? What does the accuracy look like different side to side? What does the initiation look like different side to side? All of these pieces matter because they tell us about parts of the brain that are having harder challenges or more challenged than others. Smooth pursuit to the right does not engage or bias the same part of the brain as smooth pursuit to the left. So if we're noticing a dysfunction, why are we treating both sides to the same extent? It doesn't make sense. When you look at some of the studies that are looking at vision specifically, yes, there's research behind vision and vision therapy. But when you're looking at some of the studies that look at vision as a whole, you'll also have individuals that say look at smooth pursuit and saccades. And if those are good, then they kind of like, okay, vision's good. But there's some studies that actually look at vision, even in that functional component, you can actually break it into two more components. And the smooth pursuits and the saccadic dysfunction tend to be linked more when there's also some vestibular dysfunctions happening for sure. And you could actually separate it and then also be like, those could actually be okay. But then there's convergence accommodative issues. And that can be its own kind of vision subtype group that also is predictive of longer recovery. So we need to make sure we're looking at all the components. The other piece that we want to look at is suppression of our eyes, right? When we're looking at suppression of our eyes, it's more like, it's not that we can't see. It's not that we're blind. but it's more like the brain just kind of shuts down the information coming in through an eye, right? So do we have a dominant eye that's doing all the work? Are we shutting down information of the other eye? And why might that be happening, right? Why might that be happening? What is our ocular alignment? How are our eyes positioned in those lovely eyeball sockets? And do they want to deviate out like an exophoria or deviate in naturally? And so we're constantly, when we're in light, having to correct where our eyes are in space because of visual environment. Is it actually, and are we getting this visual motion sensitivity piece because our other systems, our vestibular system and our somatosensory system, are not working as well, or we're not weight shifting between our systems? And so we're becoming very visually dependent. And so when then our visual world starts to move, that can induce vertigo or dizziness, right? We can tell so much about the physiology that's happening by using our eyes. And there's also this, I'm going to say this construct that whenever we're looking at the eyes for outcomes, we deem it as vision. So what we've talked about so far with the saccades and the smooth pursuits and the convergence and the accommodation, those are all very functional vision tasks that help control how our eyes move in our head and adjust to take in our visual world, right? Those are voluntary activities that we engage in to take in our world. But our eyes can also have involuntary eye movement. And after a concussion, this is a key piece for us to figure out. This is why looking and understanding eye movements is so important, truly, because they can tell us information about our vestibular system, right? When you think of someone that has BPPV, so the crystals in the inner ear, they describe vertigo, but we know its presence because of how the eyes move when we move the body a certain way, right? When we put you in the dark, so we take away your ability to look at an object, one of the biggest things I'm looking at in my assessment is, do we have involuntary eye movements? And sometimes you'll hear clients say a lot of the time, my eyes feel like they're constantly jumping around, or like they just feel like they're never calm. But then when you assess someone in the clinic in room light and you have them look at an object, you're not seeing that because they're able to cancel it out with fixation. But when you put them in a dark, you start seeing a square wave jerk potentially, or a nystagmus, or who else knows what else. Their eyes are darting all over the place because they have no idea where they are in space. You start to have an idea of where they think up, down, left, and right is. The information we can gather through our eyes is so valuable. Now, I realize I can be frustrating for people sometimes because I don't tell you how to treat it, because everyone is different. But from that assessment perspective, from a physical therapist, well, here's what I want you to start looking at, or a chiro or an AT or whoever's doing this, or a client. I want you to start paying attention to when I'm assessing the functional vision components. So smooth pursuit, saccades, convergence, accommodation. When I'm assessing those pieces, what am I noticing in the quality of movement of left versus right, up versus down? And what does that mean about the parts of the brain that are impacted? So go deeper than just looking at, does this give me symptoms? And so my treatment's just going to be looking at practicing smooth pursuit 1,000 times. Go deeper. So you're going to look at that piece. Then we're going to look at, what does peripheral vision look like? Do they have a dominant eye? Are they suppressing an eye near or far? All these pieces from a processing perspective matter as well, right? I had a client, he described it so well one day. He said, Natasha, when I'm reading things close, he's like, I feel pretty good. He's like, but then I start to look away and I literally feel like I'm looking at something through one eye or an eye shuts off. And I was like, and sure enough, when we assessed him, and we used a Worth 4-dot assessment for clinicians who want to Google something, he was suppressing it far. And I've actually never been able to hear someone say that or actually feel that thing. So when I say to clients, share with me what you feel in regular words, because that's going to tell me so much more than you coming in and saying my smooth pursuit's not great or my saccades aren't great. tell me when I look here quickly, I feel like my world shakes, right? Or when I'm trying to follow an object with my eyes, I feel like the world is having to like catch up and have jumps behind me, right? For me, that tells me that there's probably some saccades that are coming to your smooth pursuit. But those details, that type of language is super helpful for the clinicians who are listening. When we start to notice these pieces, right? And we determine whether are we dealing with involuntary eye movements that we pick up with when we see in the dark? Are we dealing with smooth pursuit issues? Are we dealing with saccade issues? What are we dealing with from a functional perspective? And then how do we make things harder? The biggest thing I see for clinicians is that we try to do too much too soon. When you're trying to build a treatment plan, I want you to think about it as stacking. We need to have the fundamental pieces in place first at the smallest level to then begin to layer and build into a functional task. If all we're doing is continuously practicing a functional task over and over again, but we don't have the fundamental skills to do it, it means we're trying to find a compensation or another way to achieve something. So when someone's struggling with smooth pursuit, some of the things I see, because in many courses, and it's not wrong, but in many courses, it's taught to look at a pen tip as your target, or a small letter X, like a 12-point font X on a popsicle stick. That is the assessment. But if you're trying to treat smooth pursuit, for example, and you go to use a 12-point X on a popsicle stick, and you try to do a smooth pursuit, let's just say to the right, and the eyes are jumping all over the place and they can't keep track of it, why would we keep practicing that exercise over and over again? Why wouldn't we use some of the other tools that we know that can help facilitate smooth pursuit to be achieved? So let's give you some examples for this one. Again, this is not how you treat it. These are things that you would have to look at and trial and understand more of what's happening with your client too. So you're going to look at, for example, when they actually do it, do we have a nice smooth trajectory, or are there certain muscles extraocularly that are taking over more than others? And so you might have to train different directions more to build up a certain muscle group, right? But when we're looking at smooth pursuit, one of the variables that you can look at is your target. If things are more luminous or more shiny, it engages more attention to the brain, so they might potentially fixate on it better, right? The fixation is also a huge cerebellar component, right? So, but they might be able to fixate on it better. If it's an object that is important to them or has salience, they may stay with it longer, right? Size of the object matters. Like these are just 3 things you can play with in terms of the target that might improve the smooth pursuit. And then you work your way, you find one that works. And then the progression is working back to a more complicated target. Smooth pursuit to the right has a strong, not just, but a strong right parietal lobe component to it. Well, what else gets processed in the parietal lobe? Sensation. So what if, as you're doing a right smooth pursuit, you're adding a sensory stimulus? It could just be, one of my favorite things to use is one of those like back scratcher things from like London Drugs, like $3. And I apply that to, say, the person's left leg as I'm doing a right smooth pursuit. Why am I applying it to the left leg? Because it's a contralateral communication and processing of sensory information into the brain, right? So I might have that sensory stimulation while I do a smooth pursuit. The progression, you would remove the sensory stimulation. Speed. Do I need to go slow? Do I need to move fast? If we're really struggling, do I combine moving my world with my eyes? So again, when you're looking at smooth pursuit on that objective assessment, one of the things you're looking at is, do we have a catch-up saccade so the eyes can't keep the target and they're slow and behind it, so it's constantly jumping to catch up to the target? Or do we have something called a saccadic intrusion, so the eyes are moving to the right and then they jump backwards, right? Or is there beats of nystagmus that get thrown in there? So all these different pieces matter. And then depending on what those pieces is going to help drive. So if someone has saccadic intrusions happening, which means it could be an attention issue, it could be distraction, it could be that they're not focused on the target and so they're being drawn with the world behind. If you start to play with the ability to move their world with them, can that help? Of which then the world would stop and then you might move the opposite way. So there's so many different ways to treat the visual component, which is why you're never going to see me say, here's how you do X, Y, and Z. It might be, here's some things for you to think about, to consider, like we just kind of did in addressing a visual treatment. But it truly comes back to as well, what part are we addressing? So this is where symptom provocation as an outcome measure is a fabulous piece of information, but it is not enough to build a specified individualized treatment plan. This is what we talk about in the Concussion Nerds program all the time. And anytime I lead an acute concussion workshop, yes, we absolutely bring up the VOMs and talk about the VOMs because it is a standardized, validated measure. It is what is in all the things. But I make you go deeper with it to get more specific information so you can build a more specific treatment plan for your client, because we know specificity will help recovery. Vision is a huge component, right? And then there's also this piece of like, well, when do I do this? And to me, we all know that I love integrating the things that we do. So in a treatment session, particularly if there's a visual component and a vestibular component, we can use vestibular to help with vision and somatosensory as well, especially if it's a spatial awareness component, right? So in our treatment sessions, it may be that we do some vestibular components and then we thread in vision and then we go back to vestibular and then we feed into the neck, depending exactly on what we're doing with this person. I strongly believe in the rehab dance and the integration and utilizing the systems to challenge them and let them recover by challenging something else to start to make forward progress. That being said, there's many people who do amazing things with neurooptometrists. What physical therapists and chiropractors and many other professions don't have the ability to utilize is the concept of prism, right? So prism will go in a lens and it can help adjust how vision gets interpreted with ocular alignment and all these other things. It can be a very valuable tool, especially as a management tool, and is then utilized in treatment to help you move forward. And as your visual processing and visual functional vision improve, then typically what happens is the prism gets decreased. Okay. So while we need to understand some of the things and the neurophysiology and these components of these are the pieces we need to be assessing when we look at vision, because it's a real thing. Because if our eyes are not being able to take in the world properly, so let's talk about this from a different angle completely for a second. If every time we try to follow an object with our eyes and it's jumping, that is an error signal, right? That's an error. If every time we try to look at an object, our eyes are not accurate and we have to correct, that is an error. And a few errors are not a problem, but when visually, if there's error after error after error after error coming in, when we think of the autonomic nervous system and its job is to process or take in our environment and decide if we are in safety or threat, and I always say error, and everything we're doing visually is producing error signals, then that could be contributing to your increased presence of sympathetic dominance in your nervous system. And so you can be doing all the autonomic tools you can think of, but until you also address the driver of what's driving the error signal, that part isn't going to go away, right? So this isn't just vision. This is also how vision then integrates with fight or flight and safety and autonomics and dysautonomia as well. Anything that's producing an error signal won't necessarily, but can trigger us into error or threat or fight or flight. We know that after concussion, we're in a higher level of sympathetic dominance. The research shows that over and over again. And so we want to do everything in our power to shift out of that. And so this is where, as rehab practitioners, comes in. It can come in. Now, what's also important is that as we're rehabbing the visual system, is that we need to supply strategies. So from vision, if you're watching YouTube, you can see me, but if you're listening to the podcast, I'm going to give you 3 strategies that we use to help with visual symptoms. So one is just any sort of overstimulation scenario, which is palming, right? So palming, you rub your hands together so they're nice and warm and not cold on your face. And you make 2 little cups with your hands and you place them over your eyes. And if you want to, for some people, then putting their actual hands on a table or their legs helps too, because it gives you more grounding. And for about 2 minutes, you just breathe. Eyes open or closed, whatever feels better for you. It's a beautiful tool to help decrease symptoms. And if you have eye strain, actually putting the palms on the eyes with a little bit of pressure can help decrease eye strain. What about with reading if you have to read? So remember when we were kids, way back when, and remember when you started to learn to read. When you started to learn to read, you probably either followed under the words with your finger to help you know where you were in place. Or you might have had a ruler that moved with you as you moved down the pages. Or you might have had a blank piece of paper that moved down the page with you as you read too. Pull those habits back into place because it will help guide your eyes on where to track on the page. And especially if you're using the paper or the ruler, it also reduces the amount of visual input. So reduces some of the overstimulation, which is the amount of visual in front of you as well. Fun note, Jim Quick, who teaches people how to speed read and a bunch of other brain performance stuff, he teaches and tells people that you should be tracing with your finger when you read anyways. So we stopped doing this at some point in our lives, bring it back in. So that is absolutely one tool. And then the other tool, particularly for people who are having visual overwhelm and visual motion sensitivity, is this concept of binasal occlusion. And I will find a website and we'll post it in the show notes that teaches you how to do a binasal occlusion. Or maybe we'll just create a video and post it for you guys. But binasal occlusion ultimately utilizes a pair of frames of glasses with zero prescription and the foggy Scotch tape. And what it does is you put these angled strips of tape closer over the nose period and piece. Don't use solid tape, please. Don't use solid tape. It filters out some of the information where visual information crosses over. It can also help you begin to open up your peripheral field a little bit. It's not a permanent solution. It's a strategy. And then over time, you actually want to decrease the amount of binasal occlusion you had. But as a clinician, if you're working with someone who has a lot of visual symptoms and visual overwhelm, or if you are someone yourself that has a lot of visual overwhelm, these are 3 tools and management strategies that you can utilize that help with symptom management in the task and help you to be able to accomplish the task while you're working on the rehab component. So again, that would be palming, which is like a go-to for everything concussion for me. Utilizing a piece of paper or a ruler or tracing under the words with your fingers. And then binasal occlusion are 3 very useful, powerful, easy, zero cost management tools to help you achieve some success in some visual tasks. So again, there's so much we could talk about here, and maybe we will go deep diving into some specific components of the visual piece at points. But I hope if you're a clinician listening to this, I've sparked that thinking for you to be like, okay, here's the components of vision I need to be looking at least from a functional capacity. And I cannot just look at this from symptom provocation. If you don't know what it means when you see things different left or right or speed, don't worry about that yet. If you're interested in really understanding what that is, the Concussion Nerds program is absolutely a place for you to be. But at least starting to make the observations and then reach out to a mentor or reach out to your support network and ask. But I hope that I've started to spark your mind enough to be like, I need to look deeper than just symptom provocation, but looking at the differences left to right, up to down, speed, accuracy, all these different pieces, because that matters. As a client, I hope that you feel validated in knowing that vision is more than 20/20. That yes, it can be affected in how you take in and how your eyes move and how you perceive the information. If you're a client that feels like your eyes never stop moving, then make sure your eyes are assessed in the dark. They need to be assessed in the dark. And then for everyone listening, I just hope there was something positive and awesome that you could take away from this podcast. I will be back next week, but until then, have an amazing day. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.